intelligence and the biomarker prediction in medicine. As we know, we have seen a lot of computational genomics, proteomics, and relativomics studies. Today, the task is on the concept called as pathomics. Most people work on a basic diagnostic data on a gene level or a mutation level to the maximum genome level. But what happens in the system is the key here. So, in this aspect, we do have the aspect of analyzing the tumors, getting the infiltration of the lymphocytes, and predicting the response of the treatment to the relative outcome, and whether the patient is actually satisfied for the diagnostic stuff we have made, or else the treatment selection, and then finally the epidemiology, because epidemiology is also a key factor here. Based on the epidemiology only, the epigenomics evolved. So what we do exactly in the computational pathogenesis, before in flow cytometry kind of high throughput equipments, what we do is we get the interrogation of the counted cells clustered and classified like a building models, which gives you an overview only. But the special challenge is to reproduce what a pathologist chooses to classify, and instead of using a highly detailed label block to build a new biomarker. And then when it comes to the outcome, first we need to concentrate on the tumor infiltrating lymphocytes. And when it comes to the relative outcome, it's not the normal tumor infiltration procedure we follow. We follow a spatial orientation where a higher dimension is being captured, and then the prognostic values are being seen. And this is not only a specific type of a cancer, it's also seen in multiple cancers. Then we need to look at the survival rate. Nowadays, there are a lot of statistical procedures. You might have seen the survival of fitness function in programs like R and the relative statistics. And by using those additional filtration, we guide the system. And then we also guide the treatment selection based on the spatial contrast as well as the cellular heterogeneity in prognosis. The key value and a higher addition is that we have a higher prognostic value. Most people were interested in diagnosis only, that's the second level analysis, but prognosis is also a key factor. And then we have a standard for the classification. So it's not a single work, it's the complete work of a consortium. They have done an immense work on breast cancer. For the other cancers also, the work is being going on. And many country and many scientists like me were collaborators for developing a potential clinical applications based on AI based methods to get the complete meaning of the tumor infiltrated lymphocytes. And we do predict the prognosis. And you can see the paper published in 2014 with the initial breast cancer. And now there are papers coming up. And I myself worked on the colorectal and the relative models. And we do have the spatial pattern for the distribution of infiltrated lymphocytes to assign functions and get the immune environment. Not only the CD8 marker, the associated CD4 markers can also be studied. And in combination, the criteria is not only in clinical level, it's also in the therapy level, because the traditional clinical medicine is not completely helping cancer, so people focus on immunotherapy based on additive methods. And recently the Nobel laureate micro RNA discovery person was also working on similar lines. And it was the work he started before 10 years came into a great picture now. And then the spatial organization of molecular correlation and the infiltration was also studied using deep learning methods. People use convolutional neural networks and relative pathology based studies. So the best paper which was published in this area is to study a pattern of 4,759 ECGA subjects, cancer related data for 13 cancer types, and they have detected with good accuracy. And the TAL pattern linked to tumor as well as molecular features give a proper outcome. Now they redefined the extension of the model and applied it to the 20 cancer subtypes. And as you can see, compared to genomics and proteomics, the pathomics exactly detects the tissue analytics for the precision medicine. Now they are trying to incorporate the pathomic based algorithm in confocal microscopy also to study the relative models. And a higher resolution detects the classification of tumor cells, lymphocytes, as well as the stromata, and the support for scoring the number of TAL in microscopic region of interest were also chosen, because even the Nobel laureate was discussing the factor associated with studying a real-time system, because initial studies were headed on microRNA were not a real-time system. It was only a racial time. So both Victor Ambrose as well as Lee discussed the real-time monitoring in confocal microscopy with respect to advanced AI and ML technologies. And generally for images, DL methods are really good, and convolutional neural network implication in confocal gives a great apart. And we do have the cellular composition in the region. And apart from the initial collaboration for breast cancer, there are additional collaboration with clinical trials also, which bring the AI component into a next level. And NIH is also one of the lead supporter here. And we have collaborations in various research places to do the complete study. And the patterns are both qualitative as well as quantitative. And the initial paper for qualitative discussion was from Alex and Raj, and the quantitative was from Arvind. As I have discussed, our packages like survival index and relative statistics and the clustering methods were all being seen. And then you can see the structural characterization of the base data of tumor to the distinctive pattern analysis for getting the real-time interest. And then when it comes to the second generation spatial pattern infiltration, you can see the noise removal and the relative image fixing as well as the relative groups. So the from the breast cancer based study for the other cancers, we have a lot of not only the published articles, some published meaningful data also from TCGA, and some results which are unpublished and under research will be published soon based on the works we do. And we study a lot of index for the tumor type. And for BRC, it's specifically with the respect to this index, but for cancers like colorectal and other things, we are finalizing the relative index. And you can see the statistically significant value, which is of very good type. And the Benjamin index also holds good. And as you can see in 2020, a very good paper came in the American Journal of Pathology, which used an automated technology to detect breast cancer and the related lymphocytes. And it has also given the risk factor analysis by univariate and multivariate methods to get the results. And the community challenge here is to integrate a lot of data, because there are very few people who can collaborate and give data. There are some places and some kind of people who don't want to collaborate and give the data for a research cause. You need to educate them and work it out. And when it comes to the AI pathology based algorithm validation, FDA is also accepting it. And the research which currently focuses on the AML algorithm validation gives the exact lymphocyte. You can see the specific area detection from the microscope, gives the rational operative index to give the quantification for the tool development. And you can also validate artificial intelligence methods for clinical use with real-time high throughput system, and get a clinician as well as a person involved in molecular biology to work together. And later, based on the training programs, people from radiology, pathology, all over the places have collaborated, and good proof of success were shown. And you can see the relative papers, which is published a part of our group, and the other groups gave us good results. And the task here is to get the real-time seen from the unseen data, and then to get the real-time index. So I'm done with my presentation, and I'm there for your questions.